क्या हुआ? हाँ ये थ्रेड पे डाल
మీ పేరెంట్స్ కూడా చాలా మీరు ఏది మాట్లాడలేదు నోట్లాగే మాట్లాడారు సార్ నెక్స్ట్ మంత్ కూడా కాదా
వాడేనా పక్కన సార్
Good evening. Are you able to hear? Hello?
Yes,
Yes.
sir.
Okay then. Let's get going with neuroelectrophysiology basics, concepts, and myopathy and MND. In particular, there will be at least 7 questions interactive in the process. So we have already done about 4 or 5 classes in Zoom platform, and you can refer them whenever it is possible. So the objective is to better understand the basic concepts underlying nerve conduction studies and the technical aspects, localization with electrodiagnostic studies, and a brief review of pertinent anatomy and physiology, nerve conduction studies, sensory motor mixed nerve, axonal demyelinating patterns, and study patterns in neuromuscular disorders and what we usually see here. So these are the important issues which we are going to discuss today. So the electrodiagnostic machines you all are very much familiar with. It's useful for diagnosing neuromuscular conditions, practically any pathology in the peripheral nervous system. So what you do is before starting examine, obtain a focused history and examination. The clinical impression and differential diagnosis you think in your mind before you set up your study. And you design a study of what I'm going to do in the upper limb, what I'm going to do in the lower limb, what are the nerves, is it median, ulnar, radial, brachial plexus, superficial, peroneal, or is it posterior tibial, like that you study. Every study is
എന്തോ എണ്ണയൊക്കെ ഇല്ലേ നോർമൽ എണ്ണയല്ല
so
ഈ
please
മിക്സ് ചെയ്ത് 2-3
please mute everybody. Please mute, please. So every study is individualized based on the question, exam, and differential diagnosis. What is the goal? If you look at the goal, it is localize the disorder and assess its severity. Usually, the exact etiology cannot be defined. It cannot tell whether a polyneuropathy is due to diabetes or versus chemotherapy, but only it can diagnose the syndrome that it is, yes, it is a polyneuropathy. So with these things, we'll go on to the next slide. The recording electrode types, the ring or clamp electrodes, bar or disc electrodes, which you must be using, the needle electrodes, which we occasionally use, but not always. And you got a G1 electrode and a G2 reference electrodes. You can see them, how they are attached here. And for the motor, that is compound muscle action potential, you got a G1 electrode, which is on the belly of the muscle, and G2 is on the tendon. and you stimulate distally and proximally. There is an anode and there's a cathode, and you have to measure the distance between cathode to cathode or anode to anode for the conduction, for calculating the conduction velocity, which you are going to see. For the recording of snap, you can have a G1 electron, G2 electron, which are shown here, and you can stimulate the sensory nerve and you can obtain the potential. So obtain waveform to free of artifacts, you require grounding. So ensure your grinding. And if you look at the machine settings, you got three important things, that is gain, sweep, speed, and filter settings, and which are documented down below. And gain is sensitivity, the vertical axis. The gain is a vertical axis. It represents response amplitude in microvolts or millivolts. So the gain can be increased or decreased by increasing the sensitivity or otherwise. And the sweep speed is a horizontal axis. It represents how long an action potential can last. That is the sweep speed. And the filter settings like low and high filters, which we use so that artifacts are not there. The red anode and black is cathode. That is conventionally. The stimulation duration is usually 0.1 to 0.2 milliseconds, and intensity can be seen here, and you can see the intensity. So supra maximal intensity was what you usually use. And okay. Right. So what are the goals of electrodiagnostic studies? Usually it's a localized. It's important to know the peripheral nervous system anatomy first. That we are going to see a bit. What is our goal? It is localization and severity. The localization means where is the problem? Is it the muscle, the nerve, or neuromuscular junction? And in the nerve, you have to see whether what type of nerve problem we are encountering. Is it axonal neuropathy, demyelinating neuropathy, like that? So the differential diagnosis is narrowed down once the disorder is localized. And we'll take an example. An example of ulnar nerve. Patients with weakness of hand and numbness of the fourth and fifth digits is usually by and large ulnar nerve. But if you look down from the brachial plexus, the ulnar nerve is originated from the lower brachial plexus and CHT1 nerve roots. And CHT1 and of course the medial cord, and it enters into the last. So you can look at the CHT1 neuropathy, radiculopathy, plexopathy, mononeuropathy, polyradiculopathy. And so all you have to differentiate the ulnar nerve from the distal to proximal, where it is going. Where is the problem? Is it in the nerve, or is it in the brachial plexus region, or is it in the root? So all three look alike when the clinical presentation is. And moreover, most of the nerves what you test are only peripheral nerves. So EMG is a must to come to a conclusion. So take a brief history and perform a limited exam. Formulate a study based off differential diagnosis and number of nerves and limbs to study plan, and the special techniques are used, and almost always follows and depends on the nerve conduction findings. So it's very important for the EMG planning to know what the nerve conduction study has shown to us. You can see that it is a brief anatomy, a peripheral nerve, just brief before we go on to the particular things. The dorsal root ganglion is there. The dorsal root ganglion, and that's important. Our snaps usually differentiate what is the problem, is preganglionic or postganglionic. And you can see the muscle fibers are innervated by the ventral root, and dorsal root is for the sensory. The sensory is dorsal, motor is ventral. This is called Bell-Megendi law. So axonal nerve and muscle physiology briefly. The axonal membrane is electrically active with resting membrane potential. The depolarization leads to an action potential propagating in both directions away from the site of depolarization, which you are, in this case, in stimulation, induces an action potential that gets propagated. We record only what we stimulate and capture. The importance of correct stimulation and recording sites is emphasized here. So you have to know where to stimulate for median nerve and ulnar nerve and radial nerve, and various locations for brachial plexus and from Epps point downwards. So it is recommended that all the residents should do nerve conduction studies. And my teacher Dr. Manvir Bhatia insisted that all the JRs, the SRs only should do the nerve conduction studies. Those sensory nerve action potentials you record, compound modal action potentials you record, and mixed nerve action potential also you record. So there are 3 types of studies we plan. And see, this is the stimulation. You can see the G1 electrode, G2 electrode, the anode and the cathode, and the sensory nerve action potential is stimulated. So you increase slowly the electric current so that you get a good waveform. And once you reach the maximum waveform, if it is not increasing anymore, you increase about 10 millivolts or again up then that's called supra maximal stimulation, and you have to do that for every nerve. So snap, you can see there is an onset microvolts, it is at an amplitude is this, the peak latency, the duration, the onset latency. So you can see this is the report what we usually get for the sensory nerve action potentials. And when the antidromic and orthodromic, antidromic is what we usually do. Sometimes you may have to do orthodromic conductions also. So you can have the different method by just twisting the stimulating electrode. You can make it antidromic or orthodromic. And snaps are basically important to say that you can, whether it is preganglionic or postganglionic, and that's what is depicted in this picture. So the dorsal root ganglion, which is situated here, you can see the dorsal root ganglion, and that is the point. If there is a lesion beyond that, you will not have any snap. That means snaps are abnormal. If there is a cut beyond the dorsal root ganglion, if it is preganglionic, before the dorsal root ganglion, there is an abnormal sensation, but the normal snap is present. So abnormal sensation, abnormal snap. Abnormal sensation, normal snap. Normal snap means preganglionic lesion, and the normal stimulation you can see in the extreme left. So there are 3 pictures which are showed to you. And now we go to the compound modal action potential. The morphology can be seen here. You can see the type 1 fibers and type 2 fibers. Both these fibers, they go and innervate the muscle fibers, and which are depicted here. And same, you anode and cathode, you have seen. So the CMAP also has, it is in millivolts. That is, you must have seen the microvolts. Snap is in microvolts and CMAP is in millivolts. And it has got an amplitude, it's got duration, distal latency. These are the parameters which are usually studied in each compound muscle action potential. So don't get confused CMAP with MUAP, which is done in EMG. So again, you see the muscle fibers and you can see the cathode and anode and how they are connected and stimulated. And there are 2 types of stimulation. One is a distal stimulation, one is a proximal stimulation. The amplitude difference between the proximal and distal should not be much. If there is an amplitude difference, that is called conduction block. So nerve conduction velocity, how do we calculate? I said the distance between 2 anodes and 2 cathodes and proximal and distal, and is equal to the distance divided by proximal latency, that is depicted here, minus distal latency. You usually don't calculate. What is important for the technician or the resident is the measurement of the distance. You should be perfect. If you do it correctly, then you get nerve conduction velocity correctly. That is calculated by the machine automatically. So what you feed is only the distance. And distance has to be, as shown you earlier, distance has to be between one proximal anode to distal anode or proximal cathode to distal cathode. So this is why we do to see that distance and all, that is motor nerve conduction velocity. So mixed nerve action potential, where do we test? This is usually in carpal tunnel syndrome. You can see mixed nerve action potential capture both motor and sensory fibers. It's used in usually in orthodromic setup. You can see, you can record the action potentials, and that's a different study that we'll do later, and it can be done in dorsal tunnel syndrome in the foot also. So now we just after brief introduction, we'll go on to what is axonal versus what is demyelinating patterns. So axonal loss is reduction in the amplitude. You see the reduction, this is the amplitude which is seen, and this arrow says that it is reduced. And reduction in amplitude visible in about 3 to 5 days. The snap amplitude goes in 6 to 10 days. The preserved latency and the conduction velocity. The conduction velocity and the latency are preserved in axonal loss. There may be mild reduction with loss of fast conducting fibers, but not within the demyelinating range. So low CMAP amplitude represents loss of motor nerve or muscle fibers, or there may be a neuromuscular junction block. So NMJ also will give rise to a low CMAP, but the conduction velocity is to be normal, latency to be normal. And you see what is normal. When do you call the electrodiagnostic features are predominantly axonal neuropathies, and there is a reference given here. So when do you call this? If the CMAP is less than 50% of normal, then it becomes abnormal. CMAP should be less than 50% of normal. So normative data you have to create for your own lab. Look at the normal value, and if it is less than 50, that becomes axonal. The conduction velocity also, it has to be increased more than 70% of normal conduction velocity, and distal latency also to be prolonged and more than 130%. So all these parameters are taken into consideration in declaring a particular abnormality. Now you just don't go by just small decrease here and say that it is axonopathy. You have to have clear-cut parameters. Low amplitude with mild slowing in milder cases to absent in severe cases. In that case, then you do EMG, where you can see fibrillations, which also suggest axonal loss, uncompensated denervation. In length-dependent processes, this shows a distal gradation. In polyradiculopathy neuropathy, fibrillations are seen proximally and distally also. So you have to pick up muscles in proximal as well as distal. What we usually do, extensor distorum brevis, and we go on to tibialis anterior and a medial gastrocnemius and vastus lateralis, followed by you go on to the paraspinal muscle. So you can see, depending on the abnormality, you can diagnose. The myelin loss, that is demyelination, the reduced conduction velocity, that is the conduction velocity is very much reduced because the saltatory conduction is affected. The myelin loss, the saltatory conduction is not facilitated. The jumping from one node of Ranvier to other is curtailed. So you have a reduction in the upper limbs as well as lower extremities. There will be prolongation of distal latency, and there may be conduction block, then the amplitude may be reduced. So there, the electrodiagnostic features of predominantly demyelinating neuropathies less than 50% of normal CMAP amplitude. Conduction velocity also less than 50% of normal. The distal latency more than 130% of normal. There may be conduction block, and there may be F wave latency. So whenever you do nerve conduction study reporting, first we pick up motor nerve conduction studies. In motor nerve conduction studies, you talk of CMAP, you got a distal latency, CMAP duration, and whether there is any what do you call and then conduction velocity. The three parameters you do, and you also look at the dispersion of the CMAP. And after that, you look at the F wave and what is the F wave latency. These are the parameters which we do for motor nerve action potentials. So normal nerve response arrives at the recording electrode almost together. So there is no dispersion. Whereas whenever there is a demyelination, what happens? The responses arrive at different times, causing a phase cancellation. That phase cancellation will give rise to temporal dispersion. The loss of synchrony in nerve action potentials results in a CMAP amplitude decrease due to positive part of one muscle fiber action potential cancelling out the negative part of the another potential. That is called phase cancellation. That phase cancellation will give rise to temporal dispersion. And conduction block. You can look at the conduction block, distal stimulation at the wrist, proximal stimulation at the elbow. The amplitude you can see in both, there is a difference in the left side. The temporal dispersion on the proximal stimulation, so there is some amount of CMAP coming up. So both these traces show demyelination in median motor studies. The trace which is on the left side shows almost complete contraction block with an absent response with proximal stimulation. The trace on the right shows temporal dispersion. This is a temporal that because of phase cancellation. And this where CMAP duration increases by almost 40% with proximal stimulation. In both these situations, the CMAP amplitude with proximal stimulation is smaller. So obviously there is a conduction block, and that says it is a demyelinating polyneuropathy. Conduction block when there is failure of conduction of the sum or all of the motor neurons, motor axons. So therefore, the CMAP area with stimulation proximal to the block is smaller, that is 30% less or more compared to the distal stimulation site. For conduction block to be detected, proximal CMAP duration cannot exceed 30% of the distal. So that's how you diagnose. So an acquired demyelinating neuropathy has to be differentiated from inherited demyelinating neuropathy, which you can see in hereditary motor sensory neuropathies. Right? So in those cases, what is the main difference between these two? In acquired, there is a non-uniform slowing, conduction block, and temporal dispersion with proximal stimulation. Whereas in hereditary demyelinating neuropathies have a symmetrical slowing, absent conduction block and temporal dispersion. There is no conduction block or temporal dispersion in hereditary. It's only symmetrical slowing. That's the difference between acquired and hereditary conduction neuropathies. What happens in sensory motor? The radiculopathy, polyradiculopathy, disc herniations, Lyme polyradiculopathies. Here, the snap is normal because the lesion is proximal to the dorsal root ganglia. There may be possibly low CMAP amplitude depending on the level. Mononeuropathy. What are mononeuropathies? Example is carpal tunnel syndrome or cubital tunnel syndrome, where median nerve mononeuropathy occurs, or ulnar mononeuropathy at the elbow, cubital tunnel syndrome, tarsal tunnel syndrome in the lower limb, where there is a focal demyelination and or low snap and CMAP amplitude in the single nerve territory. Exact location only possible with demonstration of focal demyelination. That's what we do is inch technique. Inch by inch, you go on stimulating the nerve. And polyneuropathy, generalized polyneuropathy is seen in diabetes, chemotherapy, vitamin deficiencies. You have to study enough nerves to establish pattern and symmetry. So what we usually teach is 3 limbs you have to test for polyneuropathy. Determine whether it is axonal or demyelinating. In report, you have to mention that. If demyelinating determines the hereditary versus acquired, and we have just read about the differences where uniform slowing is suggestive of hereditary. Late responses also, you have to consider the late responses or F wave, H reflex. All these are late responses. Usually in demyelinating neuropathies, the F wave latency is prolonged. Though nerve condition states are normal in small fiber sensory neuropathy, and that means the patient presents with burning sensation in both feet. You are able to elicit reflexes. You tested the pin prick, it's normal. Then that is suggestive of small fiber neuropathy, and it's usually motor nerve, the sensory nerve condition studies are normal in this. The plexopathies, radiation injury, trauma, neuralgic amyotrophy. So plexus usually have got very few etiologies. One is trauma, the other one is cancer infiltration or radiation. So the expanded study, for suppose you do stimulation of median nerve at the wrist, at the elbow, and in the axilla and apse point. That will cover all the, that C8T1 lower trunk, medial cord, and C8T1 roots. All are covered. So you have to do that. And expect low amplitude snaps and synapse. The plexus is distal to the distal dorsal root ganglia. So what happens in ganglionopathy? Dorsal root ganglionopathy is very commonly seen as a paraneoplastic syndrome, and it is called neuronopathy, sensory neuronopathy. The paraneoplastic anti-Hue, Sjogren's, platinum chemotherapy, these are all cause dorsal root ganglionopathy. Non-length dependent or asymmetric loss of snap amplitude. So asymmetric loss of snap amplitude, complete absence of sensory responses, and normal CMAPs. You see no sensory response. But normal CMAP, we have to think of dorsal root ganglionopathy. And we keep coming across these cases. Some recent also, I think we saw one case a couple of days back where all the snaps are absent, but the CMAPs are normal. So that is suggestive dorsal root ganglionopathy. Motor neuron disease. Motor neuron disease examples, ALS and progressive muscular atrophy. Here the snap amplitude, sensory nerve action potentials are normal. There is a reduced CMAP amplitude, usually asymmetric with the normal latency and conduction velocity. So with this brief introduction, let's go on to the myopathy part. What is myopathy? And we'll see briefly and name the myopathies, what the electrophysiological features. A myopathy is any disease process in which the primary abnormality involves the muscle itself rather than the anti-horn cell, peripheral nerve, and neuromuscular junction. So inflammatory myopathies generally they share common clinical features, that is acute or subacute onset, proximal symmetric muscle weakness. There is no asymmetry here. Laboratory, the normal sensation, normal to mildly diminished reflexes, elevated CK, serum creatinine kinase, normal SNAPs, normal CMAPs, normal nerve condition studies. EMG findings are typical with early recruitment of brief, small amplitude, abundant polyphasias, in certain myopathies, membrane instability potentials. It is fibrillations and positive shock waves. Muscle biopsy is usually limited to identify the specific pathology. The pertinent history and neuromuscular condition examination findings are crucial in outlining strategy for confirmatory studies, whether you want to do electrodiagnosis, biopsy, or laboratory tests. So everything hinges on how you elicit history and how you evaluate clinically. The most common presenting symptom associated with myopathies is weakness that usually affect the proximal musculature more than distal musculature. Some muscle myopathies where it is distal also. Distribution of weakness of utmost importance commonly involves the proximal symmetric limbs, where weakness often presents with difficulty rising from a chair, negotiating stairs, or performing overhead activities. Severe or atypical cases can include weakness of the hand, head, neck, and diaphragm. So neck muscle weakness is very important examination point. Nobody should miss examining the neck muscle weakness. Some myopathies present with unusual pattern of weakness like scapulofibular, humerofibular, facioscapulohumeral. So there are certain myopathies which have got a different affliction of weakness in upper and lower limbs. Easy fatigability is unable to sustain a given level of force for a certain period. It's a non-specific finding associated with repetitive activities. Myalgia and muscle pain is uncommon but may be seen in inflammatory myopathies, but only 10% of polymyositis cases may have pain. Remaining thing it is weakness, 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 no pain. So don't think that if you have polymyositis, itis, there will be pain, no pain. Disorders other than myopathy should be suspected in the presence of paresthesias, although they may be subject to misperception of myalgias and muscle switching. But be careful, if there are sensory symptoms, it's not myopathy. Developmental history, including motor milestones, family history, and examining the affected family members. Pediatric patients should be questioned with great care and sensitivity as they may unconsciously omit details or carry out associated because of the guilt feeling. So these are the important things which I just mentioned. Some medical problems are associated with specific myopathies, rashes, cardiac conduction problems, usually dystrophies, cataracts, and so on. And also look for concomitant connective tissue disease, metabolic conditions, endocrine conditions, toxins, and infectious and cancer. So physical examination is completely head and toe. You look for in head, what is a frontal balding, difficulty in whistling, that will tell you the weakness in the facial muscles, and temporal wasting, and of course, the head, the neck weakness. The limbs, you look for rashes, atrophy, myotonia. If you don't look for myotonia, many a time you miss the case. So myotonia examination is very important. We have seen this happen in our OPDs also. People don't look at myotonia, they are going to miss the case. Delayed relaxation or delayed contraction of muscles, paramyotonia worsens with repetitive activity, myoedema, Gower sign, cough pseudohypertrophy, and some compensatory postures and movements, scapula winging, trapezius hump, and EDB prominence in the lower limb. You invert the foot and look for EDB, which is a characteristic feature of myopathies, muscular dystrophies. Muscle structure reflexes are initially preserved, but progressively they also diminish. They become unobtainable with profound loss of strength. The sensation should be normal in the setting of myopathy. No sensory symptoms, no sensory findings. If weakness is not obvious on manual muscle testing, you have to look for difficulty with repetitive deep knee bending, climbing stairs, running, hopping on one foot, arising from a chair or floor, arising from a squat, repeated toe raises, overhead arm raises against resistance, and toe walking, heel walking. All these things you have to test to to observe for any masked weakness. So gait evaluation may reveal lumbar hyperlordosis, waddling gait, recurvatum, wide base stance, lurching, buckling, steppage, Trendelenburg sign, or footstep. So these are the examination findings the resident has to know before you set up the. So this we have already said. The sensory nerve conduction studies look at in this. What happens in myopathy? Sensory nerve action potentials, amplitude, latency, conduction velocity should be within normal limits. Amplitudes may be encountered, maybe there may be snap amplitudes, may in elderly and edematous limbs, maybe you may not be able to elicit, but you have to be very careful to interpret the results. Abnormal snaps do not rule out myopathy as it may be superimposed or a neuropathy. So we can, if you can't unequivocally say that it is myopathy because abnormal snaps are there. Right? So they may coexist. There may be myopathy and neuropathy coexistent. The neuromyopathy. The compound muscle action potential, CMAP, distal motor latency, conduction velocity, all should be normal, but amplitude may be diminished in damaged or involved muscle fibers. These are the important findings which we are dealing with in myopathy. At least 2 motor studies in one upper and one lower limb are recommended because our main aim is not the motor nerve conduction studies. Our aim is EMG to establish. But for a minimum of 2 more motor studies, one in the upper and one lower limb is recommended. If CMAP amplitude is markedly diminished, one should rule out a presynaptic neuromuscular junction disorder, that is Lambert-Eaton and botulinum, by obtaining a CMAP after 10 seconds of isometric exercise. Typically, no increase from baseline will be seen with myopathy. The very important point, please note this. If CMAP amplitude is markedly diminished, one should rule out a presynaptic neuromuscular junction disorder also, which is present in Lambert-Eaton and botulinum. By obtaining CMAP after 10 seconds of isometric exercises, you again get a CMAP. And typically, there should be no increase from baseline with myopathy. Compound muscle action potentials, distal motor latency, we have already seen this. And next. Right. Late responses like H reflex, F waves, blink reflexes are also typically normal in myopathies unless CMAP amplitudes are severely diminished. So whenever a wasted muscle is there, don't think that you get a good F wave. The F wave will not be there. Of course, abnormal late responses may be seen in myopathy with concomitant demyelinating disorders, radiculopathies, demyelinating diseases, entrapments, and so on. So you have to be very cautious about this, interpreting whenever you encounter a demyelinating disorder and along with myopathy. So in that case, there may be abnormalities in the motor nerve conduction studies as well as the late reflexes, that is F waves. So repetitive stimulation studies can occasionally be abnormal in myopathies too. When abnormal, every effort should be made to rule out an underlying peripheral nerve or neuromuscular junction disorder. So EMG, what is EMG showing in myopathy? The needle insertion may feel thin, commonly encountered with corticosteroid-related myopathy, or it may be gritty, the varied resistance due to connective tissue replacement of muscle. So insertional activity is very important. Normal insertional activity, that is a brief burst of electrical activity with each needle motion, is typical with endocrine and chronic congenital myopathies. But it is absent in fibrotic or fatty tissues. It is increased in inflammatory myopathies like polymyositis. Increased insertional activity is an important finding of polyneuropathy. Increased insertional activity in the form of runs of positive shock waves, fibrillation potentials, and myotonic discharges can be seen in inflammatory and toxic myopathies. Abnormal, sustained spontaneous activity. What is spontaneous activity? What do you see? There may be positive shock waves,
Fibrillation specific.
fibrillation potentials, also complex repetitive charges, and also fasciculation potentials. There may be fasciculation potentials in neuropathies. They are big. So these are all the spontaneous activity. Another common finding in myopathy is myotonic discharges, which are seen in channelopathies and dystrophies. I have seen a number of times students missing myotonia. Please concentrate on eliciting all the myotonia, grip, and no reflex hammers, whatever you do on the tongue myotonia demonstrate. During EMG, contracture may be encountered that manifests as electrical silence during muscle contraction. So, what is the morphology of MUAP in case of myopathy? The duration is the most consistent parameter for measurement in evaluating myopathy. The reduction is attributed to dropout of muscle fibers within the motor unit. In one go, what you should say is MUAP is low amplitude, maybe polyphasic with increased interference pattern. Small amplitude, generally myopathic MUAPs are low in amplitude as a result of muscle damage and loss. The polyphasic potentials occur because of a dropout of individual muscle fibers within the motor unit. There is increased variability in the size of the myopathic fibers, which results in an increased range of conduction velocities. This results in less synchronized summation of MUAP, manifests as increased serrations and phases in the morphology. What is early recruitment? Concentrate here. Although the number of damaged fibers is variable, the number of motor units is unchanged before and after onset of myopathy. This is different from the neuropathic picture. Here, the motor units remain unchanged. There will be difference. The neuropathy is having there will be a motor units are disturbed. Each motor unit generates less force than the normal one due to reduction in functioning muscle fibers per motor unit. The central nervous system sees that insufficient force is being generated for the given number of activated motor units. So
Sanju Didi.
also, what it does is it recruits additional motor units at a frequency close to the onset frequency of the first motor unit. This phenomenon is known as early recruitment. It should be evoked with only.
Sanju Didi.
Will you please mute? All participants mute. Mute all. I said all. I don't know why. Yes. Right. I'll open later. So this is called early recruitment. It should be evoked with only a minimal amount of voluntary contraction. Keep in mind, recruitment testing with minimal voluntary effort usually evaluates type 1 fibers and may miss a myopathy affecting predominantly type 2 fibers, which require slightly more force. Right. So typically myopathy is present with proximal findings. Common exceptions are inclusion body myositis and myotonic dystrophy. Check proximal muscles, including paraspinals, periscapular, gluteus, and iliopsoas. The information gleaned from the needle EMG examination can be used to guide the surgeon in selecting the best muscle for the biopsy. But usually, biopsy is vastus lateralis universally standardized. Needle examination should be limited to the one side of the body, while muscle biopsies are performed on the other side. So we usually leave the right vastus lateralis, not subject it to EMG examination. Not subjected to EMG examination. What happened? The labs. What are the labs things? Electrolytes, especially calcium and potassium ions, thyroid, parathyroid function test, ESR, anti-nuclear antibody, and various enzymes, aspartate aminotransferase, lactate dehydrogenase, aldolase, and GGT. They all tested. CK is the most useful screening blood test. Although CK level may be mildly elevated in rapidly degenerating urine, it rarely exceeds 1000 international units per liter. So if you cross that, then you think that it is something abnormal. There is normal variability in CK levels depending on the gender and race. And not all myopathies have elevated serum CK levels. And as the disease progresses, CK level will not raise. CK levels do not correlate with the degree of weakness in all patients. They are elevated after needle EMG. So avoid drawing CK levels for 2 to 3 days after needle EMG. So the practice is first you give a sample for CPK. Then only you do EMG once you get the report. Till the report is available, don't do AMG. That's the important aspect which you have to learn. Muscle biopsy. Choose a muscle that is mildly involved, but not so severe that it may be impossible to distinguish myopathy from end-stage neurogenic damage. So nowadays, CT, MRI may assist in muscle selection when there is no weakness. Biopsy of the muscles on the contralateral side to avoid the effect of syringomyositis, inflammatory changes due to EMG needle. So that's what very, very important. If you do EMG on vastus lateralis on right side, don't do biopsy on that side. Open biopsy is a minor surgical procedure, and nowadays the biopsy forceps also have come, which just put a small nick and put the forceps inside. Cost I was told 4,000 to 5,000. Normal muscle fibers are polygonal in shape with a few inflammatory cells with visible but not excessive amounts of connective tissue and a characteristic checkerboard or mosaic pattern. The classification, very important for you to know what are the non-congenital muscular dystrophies. And what are muscular dystrophies? Definition of muscular dystrophy, you have to know. Duchenne, Becker, Emery-Dreifuss, facioscapulohumeral, limb-girdle, myotonic, Miyoshi. These are all muscular dystrophies. And idiopathic inflammatory myopathies, dermatomyositis, polymyositis, inclusion body myositis, necrotizing myositis. Associated systemic disease, you got HIV-related inflammatory myopathy or AGT-related myopathy, and infections of viral trichinella, cysticercosis, hypothyroid, thyrotoxic myopathy, and hyperparathyroid or hypoparathyroid disorders, corticosteroid atrophy, steroid myopathy, sarcoidosis, and toxic myopathies of alcohol, vincristine, chloroquine, electrolyte disturbances, low potassium, phosphorus, sodium, and calcium, and high magnesium, calcium also will give rise to this. And there are some non-dystrophic myopathies. These are muscle phosphorylate deficiency, type 4 glycogenosis, McArdle disease, phosphofructokinase deficiency, acid maltase deficiency, debranching enzyme deficiency, carnitine deficiency. These are metabolic myopathies usually. These metabolic myopathies to be distinguished whether this is because of glucose metabolism or is it because of lipid metabolism. The glucose metabolism chaps, they will not be able to run for longer distance. Marathon run, they cannot do, but they are good for short. Whereas the deficiency of carnitine deficiency or the lipid metabolism associated metabolic myopathies, they will not be able to do the long distance. They only do the short dashes. So glucose metabolism chaps cannot do dashes. They can do long running. The fat metabolism abnormalities, they may be able to do dash, but they cannot indulge in marathon running. So these are subtle differences which you have to notice. So non-dystrophic congenital myopathy also you should know a bit about each muscle disease. That is central core myopathy, Nemelin myopathy, myotubular myopathy, congenital fiber type disproportion. These are the characterized by neonatal hypotonia, weakness, decreased spontaneous movements, delayed motor milestones, flabby muscles, high palate, pectus excavatum, elongated faces, and scoliosis. So dysmorphic features, basically you have to look for dysmorphic features. Now let's have some questions. So you can unmute and I am unmuting current and You can unmute yourself, all of you. Yeah, now you can answer the question, but don't make any noise. Okay. Right. The first question is, which of the following would not be classified as an idiopathic inflammatory myopathy? Dermatomyositis, polymyositis, inclusion body myositis, HIV virus myositis. There are 4 questions you can answer. Which of the
D, sir.
which one?
D's.
D.
sir.
Yeah, okay, very good. So the HIV is the cause, so it's not idiopathic. The other 3 are classified as idiopathic inflammatory myopathies. Which of the following is not a typical characteristic of motor unit action potential observed during EMG of patients with myopathy? Decreased recruitment, short duration, polyphagia, small amplitude.
Decreased recruitment.
Decreased recruitment. Good. So typically myopathic motor unit action potentials increase or early. Okay. New onset proximal muscle weakness reveals findings characteristic of an inflammatory myopathy. The degree of findings is as follows. Left iliopsoas is severe. Left vastus medialis is moderately severe. Left extensor hallucis is minimally involved. Which of the following is the best recommendation? Best recommendation for muscle biopsy in this case. Is it left iliopsoas, right iliopsoas, right vastus, left external hallucis? I do not perform biopsy. So what is the best? Which one you select?
Right vastus.
Right vastus. Very good. So biopsy is very valuable in establishing the diagnosis of myopathy. So needle examination should be limited to one side of the body, whereas the muscle biopsy are performed on the other side. Recommend it is mildly, but not so severe that it may be impossible to distinguish myopathy from the end-stage neurogenic change. Right. Which of the following typically presents with proximal muscle weakness? Myotonic muscular dystrophy type 1, limb-girdle muscular dystrophy, inclusion body myositis, and polymyositis. Which of the following typically presents with proximal? Which one? D.
Limb girdle.
Girdle muscle.
B.
You say B. It presents with proximal muscle weakness. Which of the following typically presents with proximal muscle weakness? Think about it. Less noise, please.
Limb girdle.
Limb girdle, no, wrong. Limb girdle, wrong. Proximal muscle weakness, polymyositis. Say polymyositis. The other answer choices are known for having distal presentation. Distal, myotonic muscular dystrophy. Limb girdle also will have distal. Inclusion body myositis is distal. Participants, you are making so much noise. I'm muting all. Again, we'll come back. Right. So after this, we'll talk about motor neuron disease a bit, and what is ALS, and what are the findings of electrophysiology for exam-oriented and wise. The motor neuron diseases are a heterogeneous group of inherited acquired disorders caused by degeneration of the motor neurons in the spinal cord, brainstem, and our motor cortex. It can affect upper motor neurons, lower motor neurons, or both. The most famous and most common is amyotrophic lateral sclerosis, also known as Lou Gehrig disease, which affects both UM and LMN. Is the first baseman for the New York Yankees from 23 to 39, who played about games of 2,000 games, earning him the nickname the Iron Horse, who famously delivered a retirement speech calling himself the luckiest man on the face of the earth after being diagnosed with ALS. I don't know why. So primary lateral sclerosis is an MND that is characterized only by UMN dysfunction, whereas progressive muscular PMS has only LMN dysfunction. So many patients who are initially diagnosed with PLS or PMA, they will eventually progress to ALS. So if it is only UMN, we call it primary lateral sclerosis. If it is only LMN, we call it progressive muscular atrophy, spinal muscular atrophy, X-linked spinobulbar muscular atrophy, and mixed amyotrophic lateral sclerosis. Gentlemen, you should remember each very clearly and how common it is in India. What are the various, because these are the Viva questions. You get a case of ALS, you will be definitely asked about this. So just briefly remember, upper motor neuroscience is spastic weakness, spasticity, hyperreflexia, presence of a Hoffman and a Babinski response. The spastic weakness means differential weakness. In the upper limbs, the weakness is more in abduction of the shoulder and extension of the elbow and extension of the wrist and the fingers. Similarly, in the lower limbs, the abduction of the thigh muscles, extension of the knee, and extension of the ankle. So these are the important differential weaknesses. Lower motor neurons are flaccid weakness, atrophy, hyperreflexion, fasciculation. No problem. You have been reading it from second year MBBS. Till in the exam, you will flood. You will get confused. Right? So major long tracts in the spinal cord are there, corticospinal tract and dorsal columns, cerebellum, spinothalamic, spinocerebellar tract. So all these tracts ascending and descending, you have to remember for your clinical encounters. The UMN begins in the central nervous system, descends through the corticobulbar tract to the cranial nerve, nuclei in the brainstem, and through the corticospinal tract to the anterior horn cell in the spinal cord. Why it is important is you have to test the bulbar muscles. You have to do a tongue EMG also. The element includes the alpha motor neurons that originate from the anterior horn cells, the gray matter of the spinal cord, and cranial nerves that originate from the nuclei in the brainstem. So this is a motor unit. The white and the black. You can see that two types. This is the black one, and this is the white one. So type 1 motor neuron and type 2 motor neuron. So these are two types. And if earlier I mentioned to you, the early recruitment is seen if there is a disturbance in type 1 motor fibers. If there's a type 2 motor fiber disturbance, then early recruitment may not be there. So this is a catch point for the DM students. The clinical presentation, the common complaints include weakness, cramping, stiffness, functional decline. With bulbar dysfunction, complaints of sialorrhea, dysarthria, dysphagia, and eventually aspiration, they commonly occur. Cognition, sensation, bowel bladder functions are typically spared. So cognition is spared. The individuals will be knowing what you're talking, what you're discussing. So be careful. The diagnosis of MND, including ALS, is made clinically. Many experts use the revised L-Ascorial criteria to determine the probability of having ALS. Detailed history taking should aim to identify the symptoms of UMN and LMN dysfunction, and it is used to elicit UMN LMN signs in all limbs and bulbar region. Manual muscle testing will reveal weakness in the affected limbs and muscles. So increased muscle or decreased muscle tone or responses, DTJs, typically normal sensory testing. Now, how we work up? Imaging modalities of MRI, cervical spine to rule out cervical cord pathologies. Treatable conditions, vitamin B12, folate deficiencies, endocrine abnormalities, and proteinemias, you have to rule out. Perform a SOD1 gene mutation to determine whether if there's a family of MNT is there, then you do ask for it. What is the electrophysiology of ALS? It is made clinically and not electrodiagnostically. But EDX findings can support the diagnosis or help rule out alternative pathologies. Many experts use the L-Ascorial criteria. What is the protocol for nerve conduction studies in MNT? Routine motor studies for the median, ulnar, peroneal, tibial nerves are done. Routine sensory studies for median, ulnar, sural nerves are done. The late responses are F wave for the median, ulnar, peroneal, tibial nerves, and H reflexes. All these studies should be performed on the more symptomatic side. The protocol, at least 3 limbs should be sampled. The muscles chosen should be proximal and distal muscles with different peripheral nerve and root innervations. So if you look at the upper limb, what you have to do is lower limbs, I have already told you, you have to do external distal brevis, tibialis anterior, medial gastrocnemius, vastus lateralis, and paraspinals. If you target these 5 muscles, they will cover all. In the upper limb, what do you do? Upper limb, what are the muscles which we should target? Flexor digitorum brevis. What else? Adductor, pollicis, flexor carpi, radialis, biceps, deltoid, and paraspinals. Then you'll have all these muscles chosen should be proximal and distal muscles with different peripheral nerve and root innervation. If you go and check back, all these will have these same characteristics. At least 3 segments of the thoracic paraspinal should be sampled. Just avoid T11 and T12, but thoracic paraspinals are to be sampled. At least one bulbar muscle, tongue, masseter, sternocleidomastoid, or facial muscle should be sampled. So this is given in Shapiro, and you can go and see the difference. Cmaps is usually decreased due to axonal loss, but conduction velocity and latency may remain normal unless there has been significant loss of fast fibers. The snaps, amplitude, conduction velocity, latency are classically expected to be normal. These studies are abnormal, suspect an alternate or additional diagnosis. These individuals may develop vitamin deficiencies also. So either it is alternate or additional diagnosis should be suspected if snaps are present. Patients with Kennedy disease may have abnormal snaps. Late response are normal to slightly delayed depending on the amount of axon loss. There is a non-specific finding, right? Whenever there is a gross atrophy, the F is not elicited at all. EMG is the most important part of MND evaluation. It can detect lower motor neuron dysfunction before it becomes clinically apparent. So to diagnose definite ALS, lower motor neuron abnormalities must be present in 3 different anatomic site regions. Either it is thoracic, the limb muscles, and bulbar muscles. The most clinically involved muscles are tested first. But in addition, muscles in a variety of body regions, including thoracic paraspinals and accessory muscles of respiration are sampled. Involvement of these regions increases the clinical suspicion of impending respiratory dysfunction. Accessory muscles means sternocleidomastoid, intercostals. What are the EMG findings of ALS? Insertional activity may be normal or increased, but usually insertion activity is normal. There will be fibrillation potentials. Positive short waves will be present in involved muscles, fasciculations, joint fasciculation, complex repetitive charges, discharges. The spinal muscular atrophy may also be present. If MUAP is long duration, increased amplitude, and polyphasic motor action potentials, they're called joint CMAPs, joint action potentials. Increased amplitude, polyphasic motor unit action potentials, joint fasciculations or joint action potentials. So the EMG findings are reduced recruitment is a notable and common finding with a reduced number of motor units firing at a rapid rate. You have incomplete interference pattern also. You can keep on seeing the baseline. The repetitive stimulation, collateral nerve terminal sprouting may lead to instability in the neuromuscular transmission detected with a single fiber EMG or repetitive nerve stimulation. We are not touching a single fiber EMG study separately. MND imaging and ultrasound. A recent study investigated utility of MRI as well as the ultrasound also. And still there are a lot of studies are needed to assess the clinical utility of these modalities. Musculoskeletal ultrasound, the MSK-US patients with MND have increased echogenicity within the muscles and decreased muscle thickness. And one study showed that it's a potential tool to monitor the disease progression also. What happens in MRI? Compared with healthy age and gender matched controls, patients with MND have higher relative T2 muscle signals on whole body. So key points of MND, motor neuron disease, especially amyotrophic lateral sclerosis, is a clinical diagnosis that should be supported by EDX findings. There will be signs of UMN or LMN dysfunction clinically and electrodiagnostically. 3 body regions that include the thoracic, paraspinals, and bulbar muscles should be sampled. EMG of the most affected muscles provides the highest yield of information. So let us see the questions. Which of the following is suggestive of a lower motor neuron dysfunction?
C.
Spastic weakness, hyperreflexia, and fasciculating increase. Okay, agreed. That's simple question, but we'll have some complicated question also. Which of the following, we have done this. Following electrodiagnostic findings would lead you to question your diagnosis of MND. Absence of positive sharp waves and fibrillation potentials in all the tested muscles, decreased CMAP amplitudes, delayed F wave latency, normal CMAP conduction velocity normal. Which of the following electrodiagnostic?
A.
Yay. Why yay?
A.
Yes, you should have these findings. Right. It's good. Last question of this. So you can see that an absence of denervation potentials, that is fibrillation and positive sharp waves in all tested muscles, should cause you to question your diagnosis of a motor neuron disease, because they will be present involved muscles in a patient with motor neuron disease. They are present even before the changes are obvious on the body. So EMG is very important. Decreased CMAPs is consistent with the axon loss characteristic of MND. Delayed F latency, though a non-specified, may also be consistent. In MND, CMAP conduction velocity will be preserved unless there is a significant loss of fast fibers. So, last question, I think we have one more question. Yeah. Which is true regarding motor unit recruitment in motor neuron disease? Motor unit recruitment is unaffected in MND and will be normal. Is reduced with an increased number of motor units firing at a slow rate. It is reduced with a reduced number of motor units firing at a rapid rate. Reduced with a reduced number of motor units firing at a slower rate.
C.
Yes. C. Reduced motor unit recruitment is a notable and common finding with a reduced number of motor units firing at a rapid rate. So I think that's all from my side. We'll have a couple of classes more on electrophysiology and basics, and of course upper motor, upper limbs and lower limbs, and EMG separate. We'll have there are a couple of lectures in Neuro E Pathshala, and you can see them, and there are a couple of them which I'll be taking in the next 1 week for the exam going batches for the revision of all of neuroelectrophysiology. Then we'll go on to recent advances in 5-6 topics before the DM exams. That's all from my side. Anything from any questions?
Hello.
Hello.
Yeah, sir, can you hear me?
Yes, yes.
Sir, I just wanted to ask, in the AIDP criteria, it's mentioned that the prolongation of the distal latency, it should not be across the entrapment sites. And the same thing is with the conduction velocity also, that it should not be sites of the nerve entrapment. Sir, could you please elaborate this? Like, generally we test the median nerve and we test all the nerves. So which nerves should we look for?
No, median nerve at the wrist, and see entrapment neuropathy, if you suspect, then the problem comes.
Yes, sir.
Usually you have F wave latency prolongation also in demyelination. So it's not a major issue at all.
Okay.
Because you nerve in AIDP, it is all the 4 limbs are to be tested.
Yes, sir. Yes, sir. So in the lower limbs, sir, what all entrapment sites? Fiblar only, no? Okay,
Fiblar.
sir. Okay, sir. Okay. Yeah.
And
Thank
you
you,
do superficial peroneal nerve, common peroneal, and posterior tibial, 3 nerves.
3 nerves. Yes, sir.
And sural nerve. So sural nerve may be normal because it's AIDP.
Yes, sir. Yes, sir. Thank you, sir.
Okay. Chalo. If there are no questions, shall I close? Okay. Good night.
Thank you.
Good night, sir.